The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon and welcome to this afternoon's webinar on health plans and contractual relationships. I'm Gary Swartz with the American Academy of Home Care Medicine. Due to travel changes, Brent Fiorine, Academy member and board member, will not be able to join us this afternoon. The webinar outline and our objectives this afternoon: why you need to act now to maintain your patients and grow your practice, what to do to provide value for a health plan and be a solutions provider, and who to meet, reference to the growing evidence base that supports home care medicine and contractual relationships, reference to the basic regulatory requirements, and leaving some time for questions and your participation. This afternoon's webinar comes out of interest in creating a baseline of understanding across Academy members, and we recognize that there's very different experiences and locations and sizes of practice of those of you represented on the phone call this afternoon. Again, our main goal was to create a baseline of information. This will be the first of other webinars and informational materials regarding contractual relationships with health plans. Hopefully some of those of you on this call this afternoon would be able to contribute to panel presentations and also some of your experiences as part of the questions portion of this afternoon's webinar. Interesting, with all the attention on the exchanges and the expansion of Medicaid, et cetera, over the past years from the Affordable Care Act, is a realization that there's actually a great deal of vulnerability for the Medicare and Medicaid patients that your practices treat. And again, this afternoon's webinar is with the interest to make sure that everybody has an understanding of the needs for recognizes those changes in the marketplace and the opportunities and processes to establish contractual relationships. As we look at this prediction of a payer shift from 2009 to 2019, with the current time being the middle pie that's provided there, we see that over the time here from the 2009 to 2019 that there's really a flip from the traditional fee-for-service practice from the 76% to 2019 to being 29%. And again, this is an aggressive presentation of what could happen in the marketplace. We also see that Medicare Advantage is growing. It's currently about 30%, so we are moving slightly past that middle sphere. And what is available as patient population to you now without contractual relationship goes from being the majority over this time frame to being the minority of patients. And those slices of the pie, if you will, in Medicare Advantage, ACOs, and the duals demos reflects those with which you are going to need a contractual relationship in place. Also encouraging this development is the healthcare reform and also the move from what we know as volume-based fee-for-service practice to value-based practice. And this slide reflects, as many of you know, as that transition across from fee-for-service and volume-based to value-based payment, shared savings, bundled payments, partial capitation, taking on risk, and then moving to more of a full risk-bearing future. This will also reward different behaviors as we move from the volume basis to one that's based on quality and efficiency. Many of you are involved in practices with a great deal of care coordination, and hopefully will be rewarded in that environment as we move from solid fee-for-service practice with the volume-based rewards and limited coordination and shared risk-taking to one that's based on value reporting, a link between payment and outcomes, and a focus on greater care coordination. And these aspects, as you can see, really require more relationship development and agreements in place. Just to create, again, to contribute to that baseline, what a definition, simple presentation of a definition of value that's used in healthcare and other aspects is quality over cost. Some evolving examples of that value definition are appearing in the Medicare program. And just want to reference that the value-based payment modifier is coming into effect on the provider side for 2015, groups of 100 and more. In 2016, practices of 2 to 99 will be added in. This is through the Medicare program. And then at 2017, down to the individual level, including nurse practitioners and PAs, up to 6% of your Medicare fee schedule payment will be at risk if not reporting. We will talk more about the value-based payment modifier in other forms, but again, just want to mention this as an example of that move to value measures and reporting. The Academy is involved with CMS to have measures reflect your population and risk adjustment to accurately reflect your patient population condition. And in person, we will also discuss this more at the Academy meeting next year. On the hospital side, and a potential source of contractual relationships and the benefits of your services, is that one aspect of the value-based initiatives in Medicare is that for penalties for readmissions for certain conditions, and we see that the penalty percentage is increasing to next year to 3%, and the number of conditions, diagnostic categories that is involved with the program is also increasing, and this could be also a source of interest in the services that you provide. And then, as we'll get into that discussion during this call as well. So what does this marketplace look like? And again, the webinar at a really fundamental level is to make sure that as time goes on, that you're taking action now so that you'll have your patient population. The penetration of health plans in the public programs varies around the country. For Medicare, on a national basis, it's 30%. 16 million of the beneficiaries are in Medicare Advantage health plans, and that's increasing. On a state level, that may range from 0 to Alaska to 56% in Hawaii. But again, that 30% is the average. Some of our practices in Portland and Boston, for example, report that they have trouble finding any Medicare beneficiaries that are not in health plans. So it's a reality in the marketplace. Medicaid, similarly, 70% on a national basis in managed care organizations, and increasing with some states at 100%. The duals population, increasing one of policy and payment interest, 9.6 beneficiaries are dual eligibles with 2 million in demonstrations. And we also have in the Medicare program, and while it's not the public beneficiaries, an increasing number of beneficiaries or health plan members in community and area ACOs. Specifically to Medicare, this is the increase in the number of Medicare beneficiaries in health plans, and if we added the year 2014 and a projection for 2015, that last column would be 16 million. Again, the amount of managed care penetration that varies by state. The green here is the 30+%, and again, as mentioned, states of Oregon, Massachusetts among the highest, Florida as well. Other areas in the country less than there. Some of the health plans and the percentage of Medicare beneficiaries across the country who would have access to one of these companies' health plans in a local market. You can see that these percentages are are quite strong. So for United Healthcare, of Medicare beneficiaries around the country, 68% of the Medicare beneficiaries could have access to a United Healthcare Medicare Advantage plan. Humana, 83%, Blue Cross and Blue Shield, in the aggregate, 73%, with their plans defined below. Kaiser, less strong, Aetna, 33%, and so on. Another way of looking at this is by beneficiary perspective. What is the number of Medicare Advantage health plans that they might have access to consider? On a county level, the national average after the ACA, you see it declined, but now is stabilizing at the average this year was 18, in metro counties 20, and non-metro counties 11. So again, depending where you are located, you would have the experience where there's a greater penetration and availability of Medicare Advantage health plans to your patient population. One thing to note is that with all of this, again, there are 2,000 health plans, Medicare Advantage health plans across the country. Again, that's a number that's been stabilizing over the years. Some health plans enter, some exit during given years, but it's around 2,000 on the average. Half of the Medicare Advantage beneficiaries are enrolled in 4 national plans. Again, this is a few years old, but again, pretty consistent information. The data would be the case now. So between Humana, United, Blue Cross and Blue Shield plans, and Kaiser and Aetna, you have 50% of the Medicare Advantage enrollees in those 4 national plans. And certainly some of your beneficiaries would have access, or those plans would be in your marketplace, so they would be good starting points for discussions. Reference to the duals population, this slide reflects roughly the half or so of states that are involved or getting involved with demonstrations. The white on this map is those states that are not yet involved with demonstrations. But you can see that for many areas of the country, there are demonstrations underway or under development, and they often involve contractual move to managed care organizations, and that means contractual relationships in order to maintain the ability to provide care to those beneficiaries and to be paid. So what we see, again, this bringing us back to the slide, is that your patients, which were in the lighter blue during the past few years and currently, would be flipping by the end of the decade, and the payers in the 2/3 that'll pay you in the next years require contracts. Again, a concern that house call practices are as vulnerable or more than other providers and specialties. So what's this mean from a historic payer mix and then a current and future payer mix? Historically, on the left-hand side, on the fee-for-service basis, we had our Medicare fee-for-service program, Medicaid, health plans, self-pay uninsured. Did you need a contract and to be credentialed to be paid? With commercial health plans, the answer would be yes, but for the majority of your patient population, the answer would have been no. And as we saw through the circle presentation, just to describe these, moving to Medicare Advantage, Medicaid managed care, state waivers and demonstration programs, the growing and emerging ACOs, both in the public Medicare program and also private, be they provider-based or payer-based. The requirement for contract and credentialing is yes, health plans as well. Emerging opportunities in concierge and consumer products, let's say Medicast and Uber, would likely require some contractual relationship as well. So what happens without contracts? Again, the the fundamental concern is loss of patients and ability to grow your practice, and no payment absent emergency. The federal regs around Medicare Advantage health plans and Medicaid as well provide the circumstances that without a contract, a health plan would need to provide payment to a provider, a facility or provider. Generally speaking, as you render services, that those situations would not be the case in your day-to-day practice. So these are the concerns. And so the percent of your patient population that requires a payment, requires a contract to be paid for services you render will increase, and most likely has already increased. We've seen some dialogue when the listserv that, unbeknownst to some of the Academy members, beneficiaries have made decisions, or the caregivers, and they've moved over to health plans. Services have been rendered and claims submitted to Medicare and haven't been paid because that patient is now a Medicare Advantage health plan member. Please note that house calls by codes or location in the regulations are neither included nor excluded, nor is any category of licensure included or excluded. Health plans do need to provide a reason if they are not contracting with someone that was interested in contracting with them. But by a category or location of services, house calls are not defined so specifically, nor is really any other type of service. But this also provides that the potential market, due to your ability to provide cost savings, increase health plan revenue, and increase patient caregiver satisfaction, and contribute to plan ratings. So with this information, what to do now and to make a plan is to review your patient population and validate the payer source for each patient. For your patients now, communicate as Medicare open enrollment is for this year is in effect, where they can make changes in choice of health plans or enter a health plan, and also make changes to their prescription drug coverage. So that's also important from your clinical and perspective. And that period of time is open through December 7th, so I would encourage you to be in communication to your patients, whether they're on your immediate schedule or not. Identify the Medicare Advantage health plans in your catchment or practice area. Identify the Medicaid duals managed care organizations in your area as well. As mentioned before with the penalty program for readmissions, identify the hospitals that have received penalties, and actually, while that's many in the country, some are at the 3% level. We have posted a link or on the Academy site to get you to the CMS data that reflects the hospitals by state and organized by alphabet, and also on a state level. Identify the ACOs in your area and establish relationships with the evolving post-acute provider networks. What to do to provide value to a health plan and be a solutions provider, and who to meet. Would have us consider this expression that's attributed either to President Ted Roosevelt and also more recently to a management thought leader. People don't care how much you know until they know how much you care. And what's the application here? The application is here is, why will the contractual partner care about your house call services? And it requires us to learn more about how they earn revenue and what's important to them, both nationally and in a local market. So for the various categories of payers on the left, Medicare Advantage, and moving down the chart, different payment mechanisms. The Medicare Advantage programs are paid based on a bidded amount against a benchmark. If they're below the benchmark and selected on a county basis, and in business, they get to keep half of the difference between their bid and that benchmark. If they're over, they have to charge the beneficiaries for the additional amount there. Part of their evaluation is on what's called star ratings, which you can contribute to in terms of access and quality and satisfaction, etc. Diagnostic coding also through assessments feeds into update factors and payments for health plans, and so these health plans would be interested in your services for those assessments. And of course, from a payment perspective and financial perspective, reduced admissions, cost of care, and end of life cost, all important to the Medicare Advantage plans. Certainly the Medicaid managed care plans, often paid from the states on a capitation basis. HEDIS measures, again, our evaluation of quality, access, and other satisfaction measures, historically stood for the Health and Employer Data Information Set. And they, from a financial perspective, will also be, of course, interested in reduced admissions and cost. Post-acute models that are evolving, interested in producing bundled and packaged payment presentations that they can take to health plans, and so they'd be interested in your services from those perspectives. And also, as they move into shared savings environments, ACOs that are currently paid retrospectively and for any of the shared savings are understanding the value of house calls, and of course are interested in the admissions, readmissions reduction, your longitudinal care, and as they move into shared savings opportunities. Transition care management, again, reference to the slide before with the penalties and the for readmissions for certain diagnostic categories. Interested in your services for that readmissions avoidance and penalty avoidance, as well as patient care and community service. The consumer-driven companies such as a Medicast and those that are others that are developing require your services at a very basic level for their network development and to be able to offer a product and go into business in a marketplace. Considering where you want to position yourself just as a direct provider of care, or if you want to take on more opportunity and relationship with health plans, is to consider some of these characteristics of being a solutions provider to that contractual party. With that, it would be to focus on your operational strategies of building or buying a care coordination infrastructure. I'll go into a little bit more detail about this in a moment. Be willing or have to build or buy the capability to manage at-risk or high-cost patients. Be capable of moving towards an ability to manage risk, and again, as we saw that continuum from the on the earlier slide of fee-for-service practice to taking on risk and being risk-bearing on the right-hand side, and then being able to communicate your value as a solutions provider. This requires doing an assessment of your practice and your environment. That would include your clinical services, your operational capacity, your human capital and talent, the competitors in the marketplace, the payers and their interest in the marketplace, relationship and the benefits that the vendors can provide, your financial resources, and your access to investment capital. Other aspects I think that are important to consider from an administrative and clinical aspect, increasing focus on increased access and 24/7 access to practices and to interventions. what would that mean in terms of your clinical and administrative capacity and cost? We'll take a look at what that would require of your own time or bringing on others, again, both through administrative services and access, and also that of additional clinical providers as well. Assuring that there's an electronic medical record in place and that's accessible to others. Plan of care for each patient and its documentation, and its increasing importance in not only existing, as you know, for your care of your patients. Medicare will begin to pay for chronic care management in 2015. We'll do a separate webinar and provide information on that when the final rule comes out in November. But want to make sure that that's an aspect of and focus of your practice regarding chronic care management and advanced care planning. Recognition that half of services that you provide and that are important may be non-medical themselves. Evaluation of the quality of post-acute providers and your consideration of establishing preferred providers, and you may have already done this in your practice through your experience. That'll become increasingly important in the time ahead, and we'll provide some resources and toolkits, if you will, on that area, and the ability to report measures and outcomes. From a financial and population health management perspective, and moving to the ability to manage risk and take on the clinical and financial responsibilities. What is the status of your current financial reporting and understanding? Generally, an encouragement to move from a cash basis of financial reporting to accrual accounting, so that you allocate revenue and expenses across the services and for the right periods of time. Understanding the concept of incurred but not reported, or what's known as IBNR, claims and costs. Gaining an understanding of outliers and stop-loss provisions and stop-loss insurance. And finally, understanding your patient population from a risk adjustment payment for your perspective, including HCC scoring and diagnostic coding. Again, these are topics we'll go into more detail, but this is part of the assessment process for how you want to relate to contractual partners and what you think might be feasible now and some goals for the future. From a reporting aspect, internal and external, what's the capacity of collection, analysis, and reporting of data, quality, outcomes, expense, utilization, revenue, profitability. Importantly, why? You need that for internal management and external reporting, proof of value. We've also mentioned registry involvement and payments currently on the fee-for-service basis with the Medicare program of future penalties for not reporting. Please make sure that I would encourage you to submit questions and observations now throughout the webinar. So with this assessment in place, a determination of where you want to fit in the marketplace, and then the ability to then communicate that to those contractual partners. That communication, targeting an ACO, health system or health plan, or managed care organization on a state level, requires identifying the major issues confronting the information, and the right person in a specific health plan or organization is going to vary by the locality and the market, by the organization, and by the issues of importance. So what are the major market issues of that organization or health plan, and what issues can your practice help them to solve? Again, as we saw earlier, this may relate to how they are paid and are able to increase revenue or make additional profit, grow in a marketplace that we saw earlier. Could include quality measures, reduced utilization and reduced cost, assisting with issues relating to pressures in other parts of their community network.